I have for those of you who don't know me, I'm Joseph Flynn, Nephrology Division Head of Children's. And it's really a great honor to introduce our speaker today, Dr. Ray Bignall, who many of you may already know of from his health equity work. So Ray is an associate professor of pediatrics at Nationwide Children's Hospital and The Ohio State University. Ray did his pediatric and pediatric nephrology training at Cincinnati Children's, and I've had the pleasure and opportunity to work with Ray on some advocacy activities through the American Society of Pediatric Nephrology. And Ray's other hat, in addition to being a pediatric nephrologist, is as chief, I should have written it down. Oh, it should be right there, yes. Chief Diversity and Health Equity Officer at Nationwide Children's. And it's a role which I think he's extraordinarily well suited to, and I'm looking forward to learning from him again today.
Thank you very much. Good morning, everyone. It's really terrific to be here. I was sharing with many of you, this is my third time in Seattle. Each time I've arrived, there's been sunshine on my arrival. And I'm not saying I'm the reason for the sunshine. I just know I'm not the reason some of you all experienced snow the other day. I've been blamed for that, having come from Ohio. And I really just want to take a moment to say how much I really enjoyed your presentation, Sangeeta. I think we don't enough hear about our colleagues' experiences so much as we hear about our colleagues' research and scholarship. And I certainly know I knew Dr. Hingorani when I arrived to do my fellowship interview here as one of our foremost thinkers in the onconephrology space in pediatrics. But now I know you as a budding flamenco dancer. And of course, I know Dr. Hingorani for her work in food insecurity, and we'll probably touch on that a little bit here in a moment, but just really grateful for that presentation and the opportunity to be here. Similarly, my talk today is not going to focus on the ins and outs of my academic career so much as it is, I hope, something of a call to action for us. It's entitled "Out from the Gloomy Past," and I don't know if that phrase means anything to anyone in this room, but I want you to reflect on that phrase, and we'll talk about its origin near the end of our talk. But the subtitle is the focus of our time together this morning: Why Achieving Health Equity Takes Trust and Guts. So it wouldn't be an academic presentation without the obligatory objective slide, right? We want to acknowledge not only historical but present day basis for medical distrust within marginalized and minoritized communities. By the way, I use this term minoritized, not minorities, because very often in society, it is not in fact the minority group that is minoritized. As an example, I'll just use my own field of pediatrics, where the majority of our colleagues are women, and yet still women in pediatrics are the minoritized group when it comes to academic leadership within the field of pediatrics. And there are many, many other examples where we can think of dominant groups that represent a minority in quantity of the population, but not in power. And that's what we'll be discussing today. The second objective is to identify sources of trust erosion in clinical care research and society, and share some examples of social injustice that threaten our ability to achieve equity. And then finally, to recognize some strategies that we can all leverage to achieve health equity by building durable and trusting relationships with communities that we serve through transparency and partnership. I have no relevant financial relationships to disclose, but I'm always looking for some, so please feel free to find me after class today. I do also want to disclose that I'm tired and busy. This is my 1-year-old son, Liam. As you can see, we're training him up early with his nephrology, his first nephrology textbook there, Nephrology for Kids. Liam is why I am perpetually tired, but happy. Hey, Dr. Ray, room 19 is ready to see you, but they're not happy. Have any of you all heard this? When you walk into clinic, you know, maybe you just sat down at your computer, you're running late, you know the patient's been waiting for a while, you badge into the system, or I don't know how you do it if it's biometric here. This is Seattle, so I assume there's perhaps retinal scans or something very, very fancy. And then immediately your MA or your nursing colleague comes and tells you that your first patient is ready to see you and unhappy already. What a great start to clinic. You know, I really must say that in this particular case, what made matters worse was that this was a new visit for me. This is a patient I had never seen before. The patient's prior provider had recently moved away. And you know, I never met the family and they're already mad. So I asked, well, what happened? What happened? Well, I'm not sure exactly, is the response I got, but it might have something to do with the research study that they were just consented for. They took a lot of convincing and eventually agreed, but they weren't really happy about it. So, okay. And you know how when you open your patient's charts, I don't know if you use Epic here at University of Washington. When we, you know, in Columbus and Nationwide Children's, when we open up our patient's chart, there's a little thumbnail with the patient's photograph. Do you guys do that? Even in adult medicine, you care about what their faces look like. Okay, all right, that's not. I'm just kidding. I'm just kidding. And so, you know, I pulled up my patient's chart. And I saw a photo similar to this. This is not my patient. This is a stock photo from our hospital's image library. But it captures the image that I saw of my patient that day, those bright eyes and beautiful smile, thick curly hair, and beautiful brown skin. I couldn't help but smile when I saw her picture, you know, because I saw sort of a reflection of myself. And I had a pretty good idea, having heard the description from my nursing colleague and the limited information I had from opening the chart's face sheet, that I knew where this family was coming from. I knocked on the door. I walked into the room and I introduced myself to Ashley's parents. Her mom and dad were at the clinic that day. And the nurse was right. The nurse was surely right. Mom looked exhausted and anxious, eager to obtain answers for her child. Dad looked burdened and frustrated, his hands calloused from years of hard work, carrying the weight of the world on his shoulders. You know, this was sort of, you know, how you walk into the room and you can kind of make a quick assessment of what families are dealing with. And I listened to them describe their child's recent course with nephrotic syndrome. And I listened to them describe the course, and I read the description of the course from my colleague. And they weren't exactly aligned. You know, I had read in the chart prior to walking in the room that the patient had there's questionable adherence and concerns around psychosocial barriers and et cetera, et cetera. And I'm listening to the family describe how they had faithfully given the child her medication. You know, it's also a little dissonant when you hear, or you read rather, that the patient had or there's concerns for non-adherence, medical non-adherence, and yet this child's growth chart looked like a rocket ship. She had gained so much weight from the Cushingoid, being Cushingoid with her steroid administration. I listened to them also describe feelings of frustration that despite the fact that they've given her the medicine each and every day, her providers didn't believe them and they didn't see any benefit from it. And, you know, I listened to them also share their hesitancy with being enrolled in that research study, CureGN, by the way, for those of you who are curious, and that even though they eventually agreed, they felt pressured to be a part of it. They felt pressured to be a part of it. When they were finished, I told Ashley's parents that I appreciated their openness and honesty. I reassured them, by the way, that the research study was not going to involve any sort of experimentation, or it wouldn't even involve me obtaining labs that I wasn't already planning on obtaining for their child's course or care. But I actually made sure to say something else. I made sure to say something else to Ashley's exhausted and burdened parents. And, you know, I told them something that we in medicine are sometimes discouraged from saying explicitly or implicitly, discouraged from saying to our patients. I said, you're right. You're right. I told them they're right to be worried because the history of what medicine has done to Black people in this country is real and it's devastating. I told them that they were right to be worried because at the end of the day, when I take off my white coat and get into my car and drive home, I too worry about what authority figures in society might make of me as a Black man in America. And I told them that they're right to be worried because when I take my family to the doctor, I also worry about the kind of care that they will receive and whether or not they're receiving equitable treatment from those people who might not know about my academic credentials at Ohio State. You know, after I simply looked in the eyes, after this, I simply looked in their eyes and I said to them, I'm going to make you a promise. That's something else we're discouraged from doing in medicine, right? I said, I'm going to make you a promise. I said, before your daughter is anyone's research subject, she is my patient first. And I will not allow anyone to do anything to her that I wouldn't allow to be done to my own family member. I promise you that. And I looked them both in the eyes and I said this, and I was absolutely not prepared for what happened next. Immediately after I said this, Ashley's father looked at me and began to weep, openly crying. It is hard to watch a parent cry, but it is especially difficult to watch a father cry. As a father, now I appreciate that even more. We sort of sat in silence for a little while. Eventually I consoled him and he dried his tears. We spoke a little bit after that. We had a great visit, actually. I finished my history and exam, and we had a few laughs. We reviewed what the plan would be for her care, and we said our goodbyes. And I never had an opportunity to ask this father really to explain to me why he became so emotional when I said that to him. Because unfortunately and stunningly, her father passed away between the first and second time I had a chance to visit with them. A sudden heart attack that killed him. And in reality, this experience has plunged my patient deeper into some challenges. They've dealt with intermittent homelessness as a result of this. They have had to leave and stay with family members in another state and return. Each time she has returned from staying with family in another state, she has relapsed or been in relapse. Lord knows how long she may have been relapsed for, and the challenges of providing her care have only been compounded by their unspeakable loss. But I'd like to think that I understand something about what triggered his tears that day, because I believe that they were perhaps manifested over a years-long journey of fighting for his child's health, sometimes perhaps fighting for his child's health and, as he perceived it, against the people who were charged with providing her with her care. A journey for praying that her life, her Black life, mattered to the people who cared for her as much as it mattered to him. And, I'm thinking about this now as we are approaching the 4-year anniversary of the unprecedented outpouring of support for the movement for Black lives. You guys remember this, right? The summer of 2020, when we solved racism. You guys remember? What has been the legacy of those marches, of that effort, of all of the signs and all of the commitments? Well, we've seen legislation to disenfranchise Black, Brown, and Indigenous people at the ballot box. We've seen increases in anti-immigrant sentiment in our country, violence against Jewish, Muslim, Sikh Americans, violence against our Asian and Pacific American neighbors. We've seen legislation introduced in states like my own that have explicitly targeted LGBTQ children. And we see even efforts at the Supreme Court to dismantle and devalue the fragile progress we've made towards workplace diversity and inclusive schools, hospitals, and places of work for all Americans. So we're really reminded that the marches of 2020 did not represent the end of our work, but really a new beginning and just another step on what we could think of as a long road to justice for lives that matter. I love this quote. It's attributed to our founding father, Benjamin Franklin. It says, "Justice will not be served until those who are unaffected are as outraged as those who are." To understand Ashley's family, and maybe some of the families that you care for in your practice, and the families who will benefit from your research, those of you in the room who are researchers, and the countless families from countless backgrounds, races, and places in this country, we must first consider that medicine has earned the distrust of marginalized and minoritized communities across our country, and that we must learn how to earn it back. I love this. I love taking a moment at this part of the talk to recalibrate our understanding of the concept of racism. And I know that there are other systems of injustice and inequality in our country, but for many scholars, they believe that racism is one of the principal roots of this sort of injustice in our country. And we can really trace much of the, you could call them branches of injustice in America, to the twin roots of racism and sexism in our society. I don't know if any of you have heard of Dr. Kamara Jones. Dr. Kamara Jones is one of our nation's leading public health voices, and past president of the American Public Health Association, and sort of a rock star physician. I mean, there are few people. I had the opportunity to be on a Zoom call with her, and when I was participating in the White House Health Equity Roundtable series, and I was on a Zoom call with Dr. Kamara Jones. It was remarkable. At one point, I think I said something on the Zoom, and she said, like, "I want to echo what Dr. Bignall said." And I said, "She knows my name. This is remarkable." Dr. Kamara Jones. She's just a really fabulous person. I encourage you to look her up. She has posited what I believe is the best definition that exists for racism today. Okay, this is it. This is it. Those of you who, like me, love Twitter, yes, it's still called Twitter. People who care about it as a platform call it Twitter. Or you love posting things on social media. This is where you can, take a photo of the slide, share it with your friends and family. This is the definition of racism I want you to consider, okay? Dr. Kamara Jones defines racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race. And she suggests that it does three things, three very important things. Without these three elements, the stool of racism does not stand. Number one, racism unfairly disadvantages some people. Number two, racism unfairly advantages other people. After all, if racism did not confer an advantage to people in society, it would not continue to exist. But the third and final thing, the most insidious thing I believe that racism does in our society, is that it saps the strength of the whole society through the waste of human resources. Through the waste of human resources. I like to have people imagine the millions and millions of authors, scientists, inventors, artists, musicians, leaders who our society has been robbed of because of the centuries-old history of enslavement and apartheid of Black folks in the United States. Just imagine how much further our society would be if we had allowed the precious human capital of those individuals to have percolated into our world, and what we as a society lack because we have allowed those voices to be marginalized. The other thing that I love about Dr. Kamara Jones's definition here is that it's not a stretch to extrapolate how that definition could be applied to other marginalized groups. Perhaps you yourself see yourself listed in, or reflected rather, in one of these identities: women, immigrants, LGBTQ people, indigenous people, people with disabilities, people living in poverty, people living in rural America, people who've been counted out in our society. So we must first deal honestly with systems of inequality before we can heal the distrust that they render. Trust erosion in healthcare stems from bias and discrimination, and it threatens our ability to achieve equitable outcomes in kidney health. Really, among marginalized populations, that struggle is marked by this erosion of trust and our ability to achieve, child or kidney health equity. So I will argue that the presence of bias and systemic inequities in society and healthcare foment this distrust, right? The more we allow this environment to exist, the more it drives the distrust that our patients and communities experience. But I also hope to show you guys this morning that there's something we can do about it. There's definitely something we can do about it. We're not powerless to address these inequities that we see in our society. I know that when we talk about medical distrust, in fact, there's probably some of you in this room right now, because you're all smart University of Washington, nephrologists and kidney researchers. I know many of you saw this coming. You saw the slide coming. You remember your city training well, I know, about learning about the Tuskegee syphilis study, the decades-long US public health study of untreated syphilis in African-American men. And we have learned about this in our medical training. We've learned about this in our research training as the linchpin of medical distrust in the African-American community. Well, not so fast. Because as much as we know about the Tuskegee syphilis study, it's the more contemporary examples of medical distrust that should concern us more. Chief among them, for example, is the Black maternal mortality crisis that is in our country today. It includes the near-death experience of tennis icon and greatest of all time. Yes, she is the greatest of all time. There is no debate about that. Serena Williams, who many of you may know nearly died of a pulmonary embolus and had to demand a CT scan for a pulmonary embolus. Her OB staff was sort of incredulous. What do you know about? Fine, you know about tennis, but what do you know about obstetrics? I am the obstetrician. Well, it turns out, of course, that she's an elite athlete. She knows about the ins and outs of the sorts of things like a pulmonary embolus that can cut short her career. Oh, but she also has a sister, by the way, a sister who is one of our greatest athletes of all time. Her sister has an autoimmune condition. Does anyone here know what her sister, Venus, suffers from? Sjogren's disease. Sjogren's disease, another condition that can result in inflammatory mediated blood clots. She understands what is needed in this case to diagnose the pulmonary embolus. And indeed, she was successful, thankfully, in demanding a CT scan to investigate this blood clot that her physicians initially refused. Perhaps you're also familiar with the story of the untimely death of Dr. Shalon Irving, Dr. Shalon Irving was a Hopkins-trained epidemiologist and member of our uniformed Public Health Service Corps who died in Atlanta after weeks of visits to her physician team, complaining of not feeling well and being turned away and returned home. This is a photograph with her father, and her child. And her story, thankfully, made quite an impact and was highly publicized several years ago. These are the sorts of stories that our patients have. They hold them. They remember them. Yes, maybe they've heard of Tuskegee, but they definitely know what happened to their aunt or their grandmother or their parent when they were in the hospital. These are the experiences that we should be wary of as well. How many of you have heard of this myth? Black people get that organ donor blank off your ID. Have you heard people talk about this before? What's the implication? The implication, of course, being that the healthcare team will not work as hard to resuscitate you if they know that you're an organ donor. Now, of course, you and I, those of us who went to medical school, know that the step in our resuscitation where we airway, breathing, circulation, check for their wallet and look to see their organ donor status is far, far down on the algorithm, right? Of course, it doesn't exist. We don't do that. But the community doesn't know that. There's no way for the community to know that, right? And this is the sort of myth that unfortunately will actually negatively impact disproportionately communities of color who are already at a disadvantage when it comes to receiving organs. In fact, specifically in many parts of the United States, because there is a predominance of blood type B in African American and Asian communities, those are communities where it can be especially challenging to get organs to those folks when the organ supply is being curtailed in this way. Because of folks being unwilling to list themselves as organ donors from those communities. I'm really proud of the work that you all are doing here at UW. I'm going to share some of it here in a moment. Before I do, I want to just share this quote from Dr. Derek Paul. Dr. Derek Paul is he was on the West Coast, the best coast. He was at UCSF, I think, for his medical training, and now is the CEO and founder of Glass Health. He posted this several years ago on Twitter, and I just really loved it. He said, "When clinical medicine can't do any more to help your patient, but society can, social advocacy becomes the standard of care." Really tremendous sentiment. We all know, of course, my friend, your colleague, Dr. Bullock, and the brave stand that he has made to publicize his how he battles with mental health and how he has overcome the stigma of it. And he is encouraging us in the field to do the same. And I am incredibly proud of him and the great work that he's done, and really his bravery in sharing that with others. These are the sorts of things that can help to break down those barriers. Some of you may also be familiar with Dr. Kimberly Manning. She is a world-renowned physician, medical humanist, faculty member, professor of medicine at Emory University. She's a physician at Grady Memorial Hospital in Atlanta. Some of you may know Atlanta as the place where our Super Bowl halftime show was inspired these past few weeks ago. She is also a graduate of Tuskegee University, and I believe actually a fourth generation graduate of Tuskegee University. She purposefully enrolled in a COVID-19 vaccine trial in order to help encourage other members of her Grady Memorial Hospital community to be willing to get vaccinated. Really tremendous story. She wrote about that experience in The Lancet and talked about why it's so important for us to encourage participation of minoritized groups in clinical trials. I love this quote: "Acknowledging every aspect of barriers for Black Americans to enrollment in clinical trials is critical to moving forward. We are not simply untrusting. We remember. You know, I think it's important for us to stop asking why our patients don't trust us, and instead considering that maybe they remember an experience that is prompting that distrust, and ask ourselves what we must do to earn their trust back. All right. Now, where do we see examples of social injustice that imperil kidney health, and what can we do about them? I want to just share a couple papers. One of them, I can't come to Seattle and not, shout out my Seattle family. So Dr. Hingorani knows this paper very, very well. And lead authored by former fellow Dr. Michelle Starr. Food insecurity is seen in about 20% of U.S. households. By the way, 1 out of every 5 people in the United States is food insecure. That's a problem. We live in the greatest, wealthiest country in the world, and 1 out of every 5 people don't know where their next meal is coming from. This is what inspires Dr. Hingorani in her work. 60% of people, children in the pediatric dialysis unit here at Seattle Children's were found to be food insecure. And that's not a knock on the great work that's being done here in our dialysis program at Seattle Children's. I guarantee you, if you came to my dialysis unit at Nationwide Children's or most any other pediatric dialysis unit in the United States, you'd see very comparable numbers. Those patients, by the way, were also at increased risk of higher healthcare utilization, increased infection rate, and lower health-related quality of life. All things that keep dialysis medical director Dr. Munshi awake at night, I'm sure. So great. We all know these things, right? We see these health disparity papers all the time, right? I know I'm not the only one. Maybe some of you guys even do this for your journal club. That's awfully cute of you. But I want us to think a little bit more deeply about why these things are happening. We can think a little bit more deeply about this. We can consider how structural inequalities might interface with the disparities we read about in the literature in order to identify upstream targets that we can leverage to improve those outcomes. For example, let's think about housing. We know that housing status can influence dialysis options and that food insecurity is a major risk factor. Housing insecurity is a major risk factor for food insecurity. I don't have to tell a room full of kidney doctors that nutrition and CKD are inextricably linked. They, of course, lead to growth impairment and can have a negative impact on transplant readiness. That the ability to purchase nutritious foods is often complicated by families who lack income, and that over-policed neighborhoods are often less desirable for municipal investment and less likely to attract supermarkets and fresh food vendors. And of course, the increased healthcare utilization in the context of end-stage kidney disease that was found in this study is a burden to the subsidized safety net programs that our patients and families rely on. Here's another paper. This paper from some of our friends who are part of the CKID program. It's an observational study of children with mild to moderate CKD enrolled in the CKID study, and also looking at the concept of neighborhood level poverty and disadvantage. These kids had increased odds of hospitalization and increased odds of emergency department use. Again, using this approach, how can we take a step back and link these disparate outcomes to the unjust systems that can influence them? Well, economic inequality deprives these communities of the ability to build and transfer wealth and to weather these sort of health crises like having CKD. The legacy of redlining, which is very easily researched and studied here in Seattle. Tremendous evidence of the impact of redlining on the communities here in the city. The legacy of redlining exerts an insurmountable downward pressure for many of the families who suffer with kids who suffer from CKD. And, let's not forget about the impact of our environment, both the built environment and the environment that we've all been gifted in this beautiful planet that we call home, and the ways in which our mistreatment of the environment, whether it's what we put into our water or what we put into our soil, whether it's the pollution in our air that is raising our global temperatures, the impact that that can have on these deprived neighborhoods and the children with CKD who live in them. Now, one of the things I'm trying not to do anymore is just list all of the depressing health disparities statistics and leave you with that to, leave this room and feel woe is me. There's nothing we can do about this. In fact, there is in fact something we can do about this. And an example of that is this paper written by Dr. Chrisberg and colleagues. Dr. Jill Chrisberg's a pediatric nephrologist at Lurie Children's in Chicago. She was also on the Best Coast for fellowship. I wonder, what are y'all doing over here? It must be the great weather and the water. Must be the great weather and the water. Dr. Chrisberg was at Stanford for her fellowship when she started this analysis. Many of you are familiar with the changes that were made to the kidney allocation system several years ago. In 2014, that is, and in order to try to provide more equitable outcomes for patients. And what did Dr. Chrisberg's analysis find when looking at the changes that were made to the kidney allocation system post-CAS era and its influence rather on equitable outcomes for children seeking transplantation? She found that these changes improved equity, specifically time on dialysis to transplantation and odds of short-term graft loss. Now, this is remarkable because we spend so much time talking about these devastating health disparities and not as much time talking about our wins, our successes. If we appreciate that many of the social disparities that we see in health outcomes in kidney disease are the result of socially engineered problems or our inability to address problems in society, then we must also appreciate that we have a tremendous ability to fix those problems and positively influence those disparities that we see. And that's exactly what she described in her analysis. So put another way, there is no reason why kidney health disparities must remain baked into the kidney health delivery system. We have power to do something about it. We have power to do something about it. What can we do? Well, nephrologists can advocate for safe and affordable housing for all children, especially those living with CKD. And by the way, it's not just kids who need safe and affordable housing and whose kidney outcomes benefit from being housed. The work of our colleague, Dr. Tessa Novick, who is now faculty at University of Texas, proves that if you house individuals with advanced CKD, you can slow the progression of their disease. Really quite remarkable stuff. We need to improve access to and education regarding healthy, nutritious, and kidney-friendly foods. One of the ways we do this is by doing what Dr. Hingorani is doing. She is partnering with community members to understand how we can deliver healthy, nutritious foods to folks who live in food deserts. There are solutions that we can pursue. Often they're outside of the ivory tower in which we work. We could support institutional and societal policies that limit the influence of income on access to excellent kidney care. I hope my politics aren't showing right now, but I think it's a little ridiculous that the only way we can assure high quality health care, again, in the greatest, wealthiest country in the world, is if you have a job that is benevolent enough to bestow it upon you. I think that's quite ridiculous. We can do better than that. Improved patient education and health literacy can address adherence, influences, and barriers to kidney transplant listing. And of course, we should all be advocating for safe and healthy physical and planetary environments for children and families to live that optimize kidney health. All right, so building durable and trusting relationships in kidney health is our collective responsibility. It's not just the responsibility of your institution's chief health equity officer. It is everyone's responsibility. And pursuing kidney health equity is indeed our path forward. So what can we do? What sorts of things can we do? How can we respond in our clinical practice? Well, one of the things you can do is acknowledge with your minoritized colleagues and patients the racism that you see in the world around you. By the way, any of the isms you can take time to acknowledge with colleagues and patients who may be affected by them. Our colleagues and patients deserve to know that they are seen, valued, and heard. We can champion workforce diversity and inclusion through intentional recruitment, mentorship, and partnership. Now, this has become a bit of a cultural touchstone today, the idea of diversity and inclusion. And I want to be clear about this. Every single person in this room represents diversity. Every single person in this room represents diversity. Whether you came from your ancestors came from a sub-Saharan African country, or they came from the north of Sweden, I don't know. It doesn't matter. Every single person in this room represents diversity. Every single person in this room deserves to be included on your team. You have ideas and contributions that matter and deserve to be acknowledged and included. Workforce diversity and inclusion doesn't mean that we just brown up the department photograph. You know what I mean? Workforce diversity and inclusion means that we value perspectives that are different. It means that we recognize that the patients that we serve deserve to see a workforce that reflects their communities. And it means that we value the perspectives shared with us by people who are different from us. You know, I tell people all the time, the people who understand about workforce diversity the best are college football coaches. All right, so you all have just made a really great decision to leave the Pac-12 and enter the Big Ten with us here at The Ohio State University. Welcome. We're glad to have you in the Midwest. Glad to have you in the Midwest. And you know, college football coaches put together football teams that are pretty diverse. Diverse in skills, especially. If you had 10 five-star recruits in the state of Washington at the position of quarterback, and you brought all 10 of those people in, well, you'd be great at passing the ball, and you'd probably suck at catching, running, blocking, tackling, right? You cannot just say, well, these happen to be the most proficient people at such this particular task, and that's the task that you value most because maybe it's the thing you did when you were coming up, and think that that's going to create a workforce that is talented enough and understands enough what it takes to win at kidney disease management. You all need a diverse team, just like the University of Washington needs a diverse team. And then maybe if that happens, you might win a national championship. Just kidding, just kidding, just kidding. Remember, the enemy of my enemy is my friend. What is that? The enemy of your enemy is my friend, right? We hate Michigan too, so we hate Michigan too. What else can we do? We can screen for social determinants of health in our clinical practice. And then when we screen these patients, we should have something to do for them when they screen positive. Don't just screen people and be like, gee, that sucks. No, we really need to think about how we're going to positively impact their lives when they screen for these social drivers of poor health. We need to engage new voices. Engage new voices. I love doing that on social media, but you can do that within your professional network as well. Encourage both implicit and explicit bias training for your faculty and clinic-facing staff. Learn how to develop strategies that make your workspaces particularly supportive of your diverse faculty and staff. You know, I'm really proud that at Nationwide Children's Hospital, we have embarked on a journey to improve the representation of our pediatric residency program, particularly our racial and ethnic representation, to help approximate that of the community that we're serving. And we've done so in a variety of intentional ways, helping to support our minority faculty interviewers, visiting student electives, and a minority house staff organization. We're proud of that. we have a lot of work left to do. In 2022, I actually had a remarkable opportunity to give a keynote address to the APAMSA National Conference. How many of you have heard of APAMSA, the Asian and Pacific American Medical Students Association? It was actually founded by the gentleman that I took a photograph with there in the center, Dr. B. Lee, who's Emeritus Professor of Pediatrics in the Division of Gastroenterology at Medical College of Wisconsin. It was really exciting for me because it was the first time that I, as a minority, had been a minority in a room full of people of another minority group. I'm used to being the only Black person in an all-white space. I'm comfortable in that environment. But it was really different to be in a space where I didn't understand the jokes. There were many K-pop jokes that were made that were far above my head. A space that was not designed for me. It was not an uncomfortable space. The wonderful folks at APAMSA made sure it was comfortable for me, but it was a space in which I was challenged to see the world a little bit differently. And I was really, really honored. To this day, it's one of the principal honors of my career to have been invited to speak. And I would encourage all of you, if you're ever given an opportunity to be in a space that is different like this, take the chance to do it. Learn how to navigate spaces like this with humility and courage and understanding. And especially for those of you who belong to a minoritized group and invite people who are part of a different group, however that identity might be defined, to be a part of your space, appreciate the experience that they may be having and ensure that it is a welcoming environment for them as well. You can learn a lot from one another this way. Of course, I'd be remiss if I didn't mention my friend and mentor, Dr. Bessie Young, and the incredible work that she is doing to advance health equity, not just here in your division and for kidney health here at UW, but across the country, especially with her pathway program work, and really incredibly proud of that. What else can we do? Well, we can listen. My mama used to say, seek first to understand and then to be understood. You guys ever heard that from your folks? We can also center at the margins. Learn to create systems that prioritize the people who are hurt the most. Oftentimes, those systems benefit everyone. We should resist the urge to colonize the communities where we work. What I mean by that is to say that when you work in a space that is underserved, don't just assume that the people in that space lack intelligence or capabilities or gifts that couldn't be of benefit to solving their problem. In fact, often they don't need you to solve the problem. They just need you to back them up. The description I like to give is learning to ride your bike. Those of you who learn to ride your bike know that you probably would have learned a lot slower if your parent had jumped on the bike and thrown you on their back, right? It's not an effective way to learn how to ride a bike. Neither is that an effective way to do community-based work. Let the community lead and be the supportive hand that knows when to let go and watch from behind. We should practice what we preach. If we're going to ask, for example, members of our minoritized group to advance our health equity agenda at the institution where we work, we should be giving them FTE to support that. I know many of you have heard of perhaps the minority tax, right? This idea that people of minoritized backgrounds are often asked to take an outsized role in addressing some area of inequity that they themselves probably experience. And it's often asked that they do this without support, for free. It's a tax. It's an additional burden on them that is given. Well, I love this idea of what I like to call minority tax exempt opportunities. So if you're going to ask, for example, a colleague of yours to advance a program, a woman colleague of yours to advance a program to support women in the division, perhaps you ask that woman colleague, what can I take off your plate that will facilitate you being able to make this program a reality. I've been very fortunate to help advance this work through the Healthcare Justice Committee that we started at ASN a few years ago, well represented by my friends in this room and in your team, really doing excellent work. Our committee is slowly being subsumed by Seattle and the University of Washington, and incredibly proud of some of the work that we've done to advance care there. Last but not least, get outside, go outside. Go outside. I shouldn't tell you guys go outside all the time. This is Seattle. You know, we got to tell us people in the Midwest to go outside. We're the ones without vitamin D. But it's important that you leave the walls of your institution and go into the community. They want to see their doctors there too. They don't want to just see their doctors in the clinic. They want to see their doctors in the community, showing that they have a genuine care and appreciation for what they're doing. Really proud to have been a part of some of that work at Nationwide Children's Hospital as well. Out from the gloomy past. This phrase is a part of what has been come to be known as the Black National Anthem, the song Lift Every Voice and Sing. When the writer James Weldon Johnson penned those words at the turn of the 20th century, he saw in his mind's eye at that time the history of 300 years of enslavement, terror, and American apartheid, culminating in the collapse of the fragile and brief post-Civil War Reconstruction. He wrote this song at the end of that era as the Ku Klux Klan and racial massacres were rising in America. But even in this period, he did not leave us mired in a gloom. Here he writes in the final words of this verse, out from the gloomy past, till now we stand at last, where the white gleam of our bright star is cast. So I leave you with this question. Where will the white gleam of your bright star be cast? How will your work, your passion, your efforts cast a bright light on the future of our patients, or the future of our field, the future of our communities? Hopefully, you're considering that carefully as well. So thank you guys for the opportunity to speak to you, and I'm happy to take a couple questions at this time. Thank you. I apologize too for my voice. I've been talking a lot this week, sorry. Yes.
This will sound pretty naive, but I think from the first example, and I was not surprised when the first was here. So the picture you show, one of the biggest things we can do is just have more Black doctors, particularly men and women, and especially in the field of nephrology, where people Black community active. So I guess I'm just curious where you think we should make the biggest difference right now, where at is it the high school level, college level? And of course, there's so many things that contribute to people not being able to go that route. Sponsor people financially, more. Where should we?
The answer is yes. All of it. So I actually have two responses to that. Thank you so much for your question. What can we do to help see more Black doctors in the field? So the first answer is as early upstream as you are comfortable going, go and encourage students and young people with an aptitude or an interest, even a faint interest in medicine, to pursue it. I think there are tremendous outlets. The Student National Medical Association is a great resource. And most academic medical schools have an SNMA chapter. You can partner with the SNMA to learn, you know, how can we, do you guys have students who are part of your chapter who want to be in the lab? Do I have a lab, or do I have an opportunity for you to shadow on service. When I'm on service, would you like to come shadow me? And I think those things can be incredibly powerful. Undergrad, high school, middle school, these are places where we need to be investing in pathway programs that are going to encourage young people to choose medicine as a career. All of that is important. But I also think it's important to recognize that while it is great for us to be pursuing more African-American representation in medical school, we don't have to wait for that. Every single person in this room, and I'll, if you'll allow me, I will speak especially to my white colleagues in this room. If that father had heard a white physician say that to him, I don't know that his response would be much different. I bet you he would still feel just as grateful. You know, I like to remind folks, this happens all the time around election season. People assume that Black voters want to vote for Black people. And you'll actually see some political parties that will remain nameless for this discussion. They'll just sort of put up Black people. Maybe they're not very impressive people, but they're Black, and they think that, oh, Black people will just naturally vote for the Black person. And it doesn't work very often, actually. It actually almost never works, because Black folks are used to voting for, supporting, advancing white people in society who have their best interests at heart. So I say that to hopefully encourage everyone in this room. Young people are looking for mentors. They're looking for people who believe in them and want to support them. I have almost no Black male medical mentors. It's actually, there are a couple I've gotten rid of because they were not helping me. Almost all of my mentors in medicine have been white, and they have been awesome for my career. They have been, I love them deeply. I'm grateful for them and what they have poured into me. The criteria for a great mentor is someone who is deeply invested in your success, period. You know, and so I hope that everyone in this room leaves understanding, yes, we need to work to diversify the field of medicine. That's great. That's very important. There's a lot of evidence behind the benefits that come to a society and a community when the medical corps is diverse. But we can also do quite a bit to help support Black families, Black communities, Black people, and by the way, other groups, not just Black folks, but other groups of people. One of the things that my APAMSA experience taught me, I'll share with you sort of a vulnerable moment from that. I'm putting together the presentation, and I said, oh, let me just include some, I do a ton of mentoring at the medical school. I said, let me just include some photos of my Asian and Pacific American mentees, you know, and that way, you know, to make it sort of relevant for them. I spent a long time looking for a picture. And with each scroll, I was more and more embarrassed. How difficult it was for me to find the photograph of a student, in particular, one student with whom I had worked. And it really shocked me, because I'm the diversity guy at my institution, right? Like, I shouldn't be having to work this hard to find representation, you know, an example of representation with this community of individuals who perhaps may not be underrepresented in some aspects of medicine, but certainly are not, there are areas where they lack representation and access as well. That really shook me, you know, and I have some mentees from other racial groups, other demographic groups, and it is a lesson that I've carried with me ever since that moment, that my job is to ensure that they feel just as supported as the mentees with whom I share racial concordance. And I hope that inspires everyone in this room to think about ways that you can do the same. Folks just want to be seen and acknowledged. They want to hear you're right. You're right. You're right that was really messed up. You're right that you've had some struggles. And by the way, I believe in you. That's what a lot of folks are waiting to hear. Thank you so much for that question. That's a great question. Yes.
This is more of a comment. I'm curious what your thoughts are.
Mhm.
And it may be dumb, but so I went to med school in downstate in Brooklyn. So about like 70 or 80% of my patients were Black, and definitely I noticed a lot of distrust when it came to medical interventions and such that I offer.
Right.
And for a couple patients that I eventually got to know and we built a good rapport, a lot of times it did come down to their thoughts on Tuskegee. A couple patients, not anecdotal, were saying like, well, yeah, historically we were injected with syphilis, and as far as I understand it, no one was injected.
That's correct.
But treatment was withheld.
That's correct.
Would have been available.
That's correct.
And what I found interesting is that, like, when you look at modern disparities, it seems to me a lot of them are rooted in things not being offered. Like, seriously,
wow.
Diagnostic tests are not done, or symptoms are not really found. Even when it comes down to the controversy over race and GFR, a lot of it is that, a creatinine for a Black patient would not be taken as seriously. And maybe sometimes it doesn't have to be, but there wouldn't even be until now with things like cystatin C thoughts to work that up further. And so to me, like, it feels like it's almost at the dumb point, like, to obsess over the exact actions that happen to Tuskegee. But I've felt in my training that the sort of misrepresentation what happened, this sort of led to the situation where intervention not being offered became a propagated problem. And I want to know what your thoughts are.
That is such an interesting and unique observation. I will tell you, I'd not considered that before you shared. I certainly don't think it's dumb, by the way. I think it's a pretty astute observation. I will definitely have to think about that a little bit more. I will say what comes to my mind immediately is a sort of confluence, the misrepresentation of what happened. You're absolutely right. It was that, in fact, when the study was started, there was no treatment for syphilis. The first several years of the public health, it was an observational study because we didn't have an intervention for syphilis. And then penicillin became available, and it was just not offered to these men. And of course, it becomes conflated because we're talking to people who have not gone to medical school, who have not done city training. And we don't talk about this in high school. This is not discussed as in our educational curriculum for young people. What exactly happened? Maybe that's a problem as well. And so you're right; it becomes misrepresented as directed harm, intentional, proactive harm. Let's say positive harm, if that makes sense. And that is indeed not what happened. And it's actually, I think you pick up on something very useful. It's not what happens most of the time. Most of the time, we ignore people. That's the problem. We ignore the person. I care for a lot of patients from West Virginia in rural Ohio, in central Ohio. I care for patients from rural West Virginia. A lot of those families come. Many of them are poor. Many of them may not smell great. Their clothes may be dirty. They may not have all their teeth in their mouth. And we, as a healthcare system, judge them. We don't like going into that room. Oh, avoid that room if you can. I know that's been a sign out I've been a part of, right? Try not to say anything to this mom if you don't have to, And this is how disparities grow, because we give them less attention, less thought, less help than we would another family with whom we're more comfortable. I think it's an excellent observation. I think it cuts identities. It cuts across identities. And I think it's worthwhile for all of us to remember that, especially when we hold bias against a particular group, we're at risk of perpetuating that problem, the sort of avoidance that can lead to worsening disparities. That's a great observation. I'm have to think about that a little bit more. Yes, sir.
I have a question. There's one of your suggestions on your slide. I'll have to admit that I'm not comfortable with. You said about talking with individual patients about systemic racism. And when I think about my approach over the years, I feel like I spent a lot of time trying to get to know that individual patient. What are your problems? What are the other things that I'm not thinking about that can affect your health?
Right.
Your family, your home situation. I'd really like to know that.
Right.
And my inclination before I heard you speak was the patients like that I'm spending a lot of time learning about them individually and,
Yes.
and what's important.
Yes.
And for example, your comment about, I'm going to treat you just like I treat my own family. I agree. That's extremely powerful.
Yes.
And a great thing to say. But I'm still not sure that I feel comfortable going over things like politics or general systemic racism on an individual patient, fearing that I might make them feel like I'm not concentrating on their situation as much as I should.
Yeah.
So what would your advice then?
Yeah.
How would you approach that? What would you say?
Well, I appreciate you sharing that. And so I'll clarify. I certainly don't think that any of us should. I'm certainly not asking for us to become experts in structural racism and then to sort of have a 30-minute lecture with our patients about it. You're absolutely right. Like, that's probably not appropriate in most of our clinical interactions. I do think we can acknowledge at times of at times of particular social distress, that these things affect our patients too. I'm thinking right now of what's happening in Columbus, Ohio. We are beginning the process for the trial for an officer who's involved in the shooting of an unarmed African-American man, a young man named Casey Goodson. In fact, Casey has family members, he's deceased now. Casey had family members who were cared for at our institution, at Nationwide Children's. They were in our primary care system. And it's deeply personal to some of the members of our clinic, the particular clinic who care for the kids who are his family. I think it would be disingenuous to pretend as though that environment in Black Columbus right now is not having a negative impact on families. Another example, we recently passed legislation that was vetoed by our governor, but later the veto was overridden in the state legislature to essentially outlaw the practice of gender-affirming care for trans youth. And I have trans patients who I love and care for with a tremendous degree of humility, and I hope provide a tremendous degree of dignity to them. It would be disingenuous of me to assume that they, as young people, and their parents, as individuals, are not affected by the environment that's happening around them. I agree with you. I don't know that I'm comfortable necessarily having a discussion, nor do I think it's necessary to have a discussion with them about the law. Like, tell me how you feel about this law being. I know, I can imagine, I know how they feel. But I use the word acknowledge. And I don't know how you do that or how I would do that. I think it's a case-by-case situation, and it comes from knowing our patients and the degree of rapport that we have with them. And I can tell you take very seriously building rapport with your patients, and you appreciate why it's important to build rapport with them in order to achieve therapeutic goals. But I do think it's important for us to acknowledge that when the time is right, that you understand that the environment they're in is tough and it could be affecting what's happening. And that's what I did with this family. When I told them that you're right, I was acknowledging that what I think and know and believe as the healthcare provider in that moment conflicted with what they brought into the room that day. They brought into the room distrust, uncertainty, frustration with years of nephrotic syndrome that was not being effectively managed. And acknowledging that their fears were based in a reality of how society treats them helped me build that rapport. And I think that there are times when, especially when we're interacting with patients who've been marginalized, and we pick up on them, on that marginalization affecting the interaction that we have with them or the care that they're receiving or how they perceive their care. I definitely think that it can help to aid in building that rapport. So yeah, I hope that helps to explain my perspective. Thank you. I saw one last, I don't know if we have time. Okay, that's fine. Yeah.
I'm sure there's more discussion to be had.
That's fine.
Thank you so much.
Thank you very much. Thank you all. Yeah.